I'm Kristin Mallon, certified nurse midwife, here with Dr. Yaakov Abdelhak, high-risk perinatologist and MFM specialist. And this is True Birth. Today we're going to talk about episiotomy, which we recently found out means appease, which is pubic.
Well, otomy always in medicine is to cut. And epision in Greek, I think, is the pubic
region.
Also, it sounds good. If I was selling episiotomies, I would come up with the name episiotomy. Doesn't it sound like, oh, I'm going to episiotomy you right through this?
Right,
delivery.
like it rhymes with easy. It sounds like
easy
peasy
right.
episiotomy. It makes me want to give birth all over again.
Lemon squeezy episiotomy.
Yeah, exactly. Like,
right.
It sounds even dreamy in some ways. No,
well, I think I'm going to go with easy peasy.
Easy
peasy episiotomy.
Yeah, I love that. So,
okay.
But no one wants to even imagine cutting and the vagina and anything about that.
What's that? There's one person out there who doesn't know what an episiotomy is. Let's tell him what it is. There's that one guy. There's one guy who's listening to our podcast who's like, what?
And he didn't get it with the pubic and the cutting?
No, he's still
like, what are they talking about?
He's something to cut.
All right, so we are talking about when you're giving birth and you actually make a cut.
The doctor or midwife
makes a cut.
Actually cuts the perineum
right.
to make more room for delivery of the head.
Yes. And I think this is a woman's greatest fear, honestly. I think more than the contractions, more than the labor itself, more than giving birth, more than a head, more than a watermelon coming through the vaginal canal. Women, don't you find that they bring this up as their number one fear all the time? The episiotomy.
Well, they don't want to tear.
They don't want to tear, but more importantly, they don't want an episiotomy.
Yeah, but our patients know we're not going to do an episiotomy.
No, we don't, right.
There's something dire. So I don't think they have to say, hey, please don't do an episiotomy. You know, that's like,
right.
Be like, please don't drop my baby.
Right. So anyway, this is a hot topic. So we're going to talk a little bit about it.
Okay. So an episiotomy is that incision that historically and still sometimes is used to enlarge the vaginal outlet to allow delivery of the head. I don't know, somebody came up with this 150 years ago, and over time, at one time it became really popular. Not like just like, oh, these are good, but like it was actually encouraged to do.
Akin to the kind of nature back and true birth way. I mean, as babies got bigger, someone probably realized like these women are tearing more. So I better do something about this. So I'm going to start to like get ahead of this.
Head of the game.
And I'm going to start to cut these women more because I'm going to be on top of this. I'm going to control this tearing and I'm going to dictate where this tearing is going to happen. And I'm going to start cutting them where I want them to tear.
So we're not going back too far. I mean, I did start my residency in 1993. And when I started my residency, the old guys who were still actually outdated with would actually tell me, because that's the way they were trained and that's the way they still believe, you should do an episiotomy on every delivery because this is a list of reasons. A, the tear will be, the cut will be straighter than a tear, so therefore it'll be easier to repair. B, it will be directed instead of going, off into the side into the blood vessels. C, it will be in the right position and they will allow the head come out without less trauma, meaning the baby head shouldn't have to cause to tear if you're actually doing a favor to the baby's head by cutting. And they had all these reasons why episiotomies were better, and every one of them was absolutely wrong.
Right. And then I graduated in 2006, and the JAMA study was actually published in 2005 while I was in school. And this JAMA study was this huge study about how episiotomies were like worse than the devil, and they were the worst thing ever, and no one should be doing them. And it was like burned in our retinas that episiotomy, if you cut an episiotomy, you basically were the worst practitioner in the face of the earth. And women were going to line up and picket at your office that you were the worst practitioner and no one should ever trust you again.
Midwives got that right, because when I was training, the old doctors would tell me, oh yeah, these are really good. And the midwives who I trained with also would say, oh, these are really bad. You really don't want to ever do that. It's much better to tear naturally. And now today, the conversation is over. Everybody knows that it's much better to tear naturally. Mainly because whenever you cut an episiotomy, you're just setting the body up to tear further. I mean, that's just the beginning. And then when the head comes out, it's going to even tear. Now you have a sharp edge that's not bounded by anything, and then it's going to tear much further, and you have a much higher chance of getting into third or fourth degree lacerations. So what are the 4 different degrees of laceration a woman can have on her perineum from a childbirth?
So we have 4 different types of tearing. Mainly, you get the first degree, which is really just of the skin.
Superficial, not even into the muscle. So just superficial, a little bit into maybe the subcutaneous fat. If it's very superficial, you don't even have to repair it. If it's bleeding or cosmetically, you might want to repair it, but that's called a first degree laceration.
Right, really easy. Second one, most common, and it goes into the muscle.
Yeah, and I would say women having their first baby, I would say 80-90% of women having their first baby will have
this type,
a second degree laceration, which is that the head comes out, there'll be a tear where the skin will break at the base of the vagina, going down till the anal area in that direction for 2 or 3 centimeters, and inwardly also, so on the skin of the perineum and in towards the vagina, and that will be kind of natural for many, not the vast majority of first-time
right,
moms.
And this is great because it heals really well. It's pretty relatively easy to repair. It doesn't really, the pain doesn't really last that long, and most women are kind of back at it in a couple of days even.
What's a third degree laceration?
Third degree is when the tear goes all the way to the rectal sphincter.
Not two, but involves.
Yeah.
So you even have some tearing of the rectal sphincter. So you have this muscle that goes around the anal area. It's circular because it's a valve muscle. And if that muscle tears, we call that a third degree. It's sometimes a partial third degree. And what's a fourth degree?
Through.
Kristin is grimacing as she says that. So fourth degree is when the vagina rips all the way through into the anus. Now you have just large opening from top to bottom. That I think that would be everybody's nightmare. Yeah,
it's pretty nightmarish, I think.
Right, and that is that's considered a major complication because first of all, it requires a certain skill to repair, and second of all, even after you repair it, there's always possibility that the repair doesn't hold perfectly, and then you get a fistula or you get a tracking or a channel between the vagina and the rectum, and that obviously would be very bad because now you have fecal material coming up at the vagina and air escaping vaginally, and really, just a hygienic nightmare and something that needs to be corrected. So,
and it's really traumatic for the women, and a lot of women will want C-sections actually when they've had fourth degrees because they want to avoid even the prospect of having that happen to them again.
Right. That could be an indication for a C-section that you had a fourth degree laceration, and I don't want to deal with that again. Although, we wouldn't advise that.
Right.
But some doctors, you had a fourth degree laceration, you just have a C-section, you don't want to go down that road again.
Right. But we would, of course, support that if that's what the women wanted. And when you cut an episiotomy, you're more likely to have a second degree turn into a third or fourth degree.
Right. So this took a while for modern medicine to figure it out. Episiotomies were introduced. They're great. Everybody should do them. One old timer told me when he was a resident, I guess this is back in the 60s, right? If he didn't do an episiotomy, he got into trouble, and he remembered having to do episiotomies after the baby was delivered to prevent his supervisor from noticing that he didn't do an episiotomy, which is, I don't even know the right word for that. That is so perverse to actually cut a woman after the baby's out to fake somebody out that you did an episiotomy when she was intact.
Right. So actually, because I graduated in 2006 and the study came out in 2005, I was like in school in between this kind of transition. And I went to school at NYU, and my training was at a New York City hospital. And we trained with the residents and the midwives. And so when we trained with the residents, a lot of them were taught you cut an episiotomy every time, no matter what, because you need to learn how to sew. So do you remember this?
I never heard that reason. I heard because you're benefiting the mother and the baby.
Right.
And I think I put this in my Nature Back book. There's a Williams quote from Williams Obstetrics, was one of the major textbooks. The baby's head is being used as a battering ram to get out of the pelvis, and the episiotomy is like sparing the baby's head from being this battering ram.
Right.
Like these crazy ideas that you're doing somebody a favor by making this incision.
Yeah. So then when we would do deliveries with the residents, it was like, they were breathing down your neck, cut the epies, cut the epies, cut the epies. And as a midwifery student, you're like shaking in your boots, like, am I supposed to do this? Is this what's right for the mother? This like ethical dilemma in your head about and then that was how you learned how to sew, was because you cut these episiotomies.
Long before 2005. I graduated in 97. By the time I graduated, I was pretty sure episiotomies were only, not to be done routinely. And maybe,
so even back then you knew?
Yeah, because people were, the midwives were telling me, no, this is not, not good. And the old timers, you got the impression maybe they were practicing from the 60s. And it became more and more obvious that this was not something you routinely want to do, although it was considered completely acceptable to do episiotomies routinely. And now it's completely not. I mean, the hospital actually monitor episiotomy
right, and you're
rates.
looked down on if you do them.
Right, and it should be. Now, when we do episiotomies, I don't know, 1 or 2% of deliveries, very rarely.
Right,
but we
if
do
that,
them.
right.
And why? Why do we ever do it in people? We know that they're bad. We know that stretching the skin is better. Mother recovers better. A natural tear is better than an artificial tear. An artificial tear is going to extend fat further. It's going to bleed more. Bad in every way.
Right.
So why do we do episiotomies?
When the baby's in distress and when we need to expedite the delivery, we sacrifice the mother as she would want, usually.
That is, I don't know, this
The way I described it?
Yes.
Sacrifice the mother for her baby? I think women are applauding right now. They're like, yes, sacrifice me for my baby.
Not sacrificing anybody. Sometimes a baby needs to come out in a hurry, and the only way to get the baby out in a hurry is to make room so that you can pull the baby out. So first of all, we generally do it mainly when we do assisted vaginal delivery, which is like forceps or vacuum, because we are trying to get the babies out and head out and
quickly.
Right. We also sometimes do the bradycardia, and you can't wait the extra 5 or 10 minutes to push the baby out. So you make a little cut and you say, okay, here's enough room. Come on, baby, let's go. Let's get out before, so that your heart rate can get back up.
And I think like most women would, and it's a good conversation to have ahead of time too, would prefer a little bit of an episiotomy, like a small episiotomy over a C-section.
Yes, I think that's a fair trade. And you and I, we have this practice, which is not really described anywhere, just kind of common sense, that we don't really do like real big cuts. We do little cuts. And sometimes as a mother's pushing, the perineum is stretched, and we can actually do a whole podcast on how to try to avoid a tear, because like how we get how to stretch the head, right? But the perineum is stretched, the head is bulging, and that there's that area of skin where all the pressure is kind of coming to this one point, and that's the area that's going to rip, and that's right at the 90 degree, right in the middle of the head, right going down, and that's where we sometimes take the scissors and we make the slightest 0.5 or 1 centimeter cut, which is not really big enough to call even an episiotomy. We call it an episiotomy because we are cutting. But what's happening is we're giving a start. We're giving it a little bit of a, like anytime you want to rip something, if you have a start, it's much easier. And
right, you're like telling it in the direction of that you want it to go.
Anybody's ever tried to open a ketchup package that didn't have that little nick in it and got,
Right.
You ever try that? It's like the most frustrating thing in the world.
Right.
Those things, you cannot open those things.
Yeah, you just got to get the scissors.
You need to do an episiotomy on the ketchup.
Right.
Right. So we make that little tiny cut, and then we let the mother push all the way through it. And that's only if we are in a specific rush to get the baby out. Most of the time, we just let the mother tear and we actually try to prevent any tear, because that's even better.
Yeah, and a lot of times when we let the mother tear, the tear is less. I mean, we assume you can't compare apples to apples. You can't be like, okay, put this baby back in.
Oh, for sure it's less. The tear, is a real episiotomy where you cut 3 or 4 centimeters and then the mother delivers, is always going to have a larger tear than if she tore herself.
Right.
Because the edge is completely ready to go further. When it tears itself, there's a boundary that builds up, a natural boundary of tissue that's getting pushed and pushed and pushed, and it actually acts as a lever, or not a lever, a ledge or a dam, where that's as much as it's going to tear. But when you cut and you have a sharp edge, then when the baby's head comes out, boom, it tears more.
Yeah.
Even when we do an episiotomy, if we have the luxury of a little more time, we make the tiniest little cut and let the mother tear, let the cut extend itself, as opposed to making a big cut for the baby.
Right.
And after the baby comes out, there's always the issue of the repair. We have to talk about the repair also, because that's actually that's a skill. That's a real skill. And
Yes. I would have to say that from someone who, that's the main surgical skill we learn in midwifery school before not counting first assisting, not counting C-section and first assisting or D&Cs and things like that. I think that was the thing that took me the longest to learn.
Right. And I tell this to my residents, I have not stopped learning. I'm still getting better. After
I agree with you.
Thousands of repairs, I am still getting better. Everyone is unique, and every single time you have to think about what you're doing, and everything has to come back symmetrically, and the sutures have to be in the right place, and every woman gets repaired, but not every woman gets repaired correctly or really well. And if I could send out an apology letter to the first 100 women I repaired, I probably should. And I would say,
well, it's not too late.
Right. It is, because I don't know them. And yeah, you don't know me. I delivered your baby as a resident. and due to lack of good supervision and experience, I'm pretty sure I did a really bad repair, and I am sorry for the pain that you experienced in the healing, and I hope you're doing better now. That's what it would say. And then I wouldn't sign my name because I would be too much of a coward to actually, call me up and yell at me. But I'm just I actually think about that, and it bothers me because I know I didn't do a good job for a while until I really got the hang of it. And when it comes to delivering babies, I always tell, my patients, it doesn't, I'll live with the resident, but the most important thing is the repair. And it doesn't mean the resident can't do the repair, but I have to be standing over their shoulder, pointing and making them think about the anatomy and how it's coming together. Because you start with a 2-degree tear, because it looks like it's this, and you end up with a 3-degree repair, because when everything bounces back, you have a horizontal plane on the cut and you have a vertical plane on the cut. When you cut, when it tears, it looks like a vertical and everything. And we've done a lot of repairs together, and every single one really have to think about. And over the years, I think I've gotten really good at it, but I still think I'm getting better.
And one of the things that I've noticed is when a woman has had an episiotomy with her first pregnancy, that a lot of times she will end up tearing along the same episiotomy.
Oh, I have
scar.
a term for that.
What is it?
I call it a Ziploc tear.
Oh, the tissue there is much weaker.
Right. And once it starts going, it just pops open.
Yes, exactly.
Right.
Because a lot of times I find that we're able to kind of, not promise, but kind of, we have less of a chance of tearing in your second, third, fourth time.
Much less.
And it's kind of like one of the benefits.
Sometimes a little tear becomes a big tear, like boom. Like,
exactly.
You're like, what happened? Like you think, I got this baby out, but then the shoulder comes out, gives you a little tear and pops the whole thing pops open.
Because they had an episiotomy
and
with
you
their
know
first.
that happened because when afterwards the bleeding is much less because it's not vascular, it was already torn.
I know. I'm just like, this stupid episiotomy that you had 4 years ago with your first baby.
This is the trivia question I ask my residents. What is my number one motivation for not allowing this woman to tear while I deliver the head, like while protecting the perineum and getting the head out? What is my number one motivation? What am I trying to avoid?
You having to sew.
You're not supposed to know the answer. You're supposed to say things like infection, hemorrhage, pain. And then I say, no, more important than that. And then when you run out of reasons why I shouldn't let a woman tear, I say, because I want to go home right after the baby's out.
I just think to myself, like, why wouldn't I want her to tear?
Right.
Like, what would my motivation be?
Lucky for the patient, her and my agenda match up. We are on the same page. And but yes, a good obstetrician wants to deliver that baby, want to have and you don't want to sit there with a suture and sewing. You generally would like to, wash your hands and go do your paperwork, congratulate her, and move on. But it does decrease the risk of infection and hemorrhage and all the other things also.
And then the healing time from an episiotomy versus a regular tear is usually better. Women who have a normal tear versus an episiotomy, they're usually feeling better, they're up and at 'em better, they're kind of getting around better versus an episiotomy. And then the healing process is usually much better. I mean, it seems counterintuitive. Like, I think that's why they thought an episiotomy was much better back in the 60s and 70s and even up until the 90s.
Why is it counterintuitive?
Because I think they thought like a straight edge cut, they thought that was better.
But that's never where it stops. That's just where it begins.
Right.
Then when the head comes out, it's a process where everything stretches and stretches and stretches. When you cut, you're not giving the body the opportunity to stretch, and then you're encouraging the tear to happen because now you got the and it's going to take it much further. So I see an episiotomy as encouraging a bigger tear to happen. That's how I see it. So of course it makes sense to me that episiotomies are going to be harder to heal from, have more blood loss, have more pain. I would like to avoid them, and sometimes they can't. And then I have to say, Mom, I need to get this baby out, and if you push for another 10 minutes, you will get the baby out without me doing anything, but the heart rate's a little low, and I'm going to give you a little nick, and then the baby's going to come out, and the little nick is a lot more justifiable, even though this is one of the things that you're not going to find in a textbook about how to do an episiotomy, like a little nick they just say cut. They cut, you take the big scissors and cut. We do the little nick because we know that sometimes all you got to do is get to start, and then the rest will tear by itself, and it won't be as bad.
And an episiotomy is usually like a 2 to 3 centimeter cut. We're not talking about like a half a centimeter cut, which is what you're saying you do.
Is directly, you're cutting a large amount. We don't know why the book doesn't say you just make a little tiny cut, and this way at least the patient, it lets. And actually, I think I learned that from the old timers. They would say, "Oh, yeah, you don't need to do a episiotomy. Use your instrument to make a little jab here, and then it would tear."
Right. So when a woman tears, just like in a C-section, like there's certain parts in a C-section where you use your hands to...
Right. Okay, but let's talk about something that really bothers both of us about if the ACOG, American College of OBGYN, I still think I don't think they've changed their stance. If you do an episiotomy, like if they say, don't do an episiotomy, they finally, they came around. Don't do an episiotomy. They're bad. If you have to, you should do a
right lateral episiotomy.
A right medial lateral episiotomy.
Right.
Okay? So think of it, an episiotomy is cutting straight down from the base of the vagina towards the anal region in that direction. Now,
like
right
a
medial
clock, like the vagina's a clock. It's a 6 o'clock.
Right. So instead of 6 o'clock, you're going to cut sideways, but not exactly 9. You're going to do like 8:30 or
like 8.
Yeah. 8 o'clock. You're cutting in that direction, and the reason for this recommendation is because the studies show that it's less likely to turn into a third degree.
Right? Because you're not cutting to the anus. I mean, there's no anus on the right side.
It extends. It's going to extend into the buttocks area.
It's not going to extend into the buttocks because the buttocks isn't on at 8 o'clock.
Therefore, it's a safer way to go. And you and I strongly disagree.
Right.
So this is one of those truths that we promise you that we'll tell you the truth.
Yeah, this is a true birth alert.
True birth alert, right? Forget conventional thinking. It is not true. Right medial lateral episiotomies are painful. They're very hard to heal from, and they are not a good idea ever. It's always better to go down. Try to avoid a third degree. Try to avoid a fourth degree by, with protecting the perineum, using your hands correctly to put pressure there. But I will never do a right medial lateral because I believe that is a very disfiguring and not, it's not natural. I mean, think about that. Why wouldn't the body tear in that direction if that was the right way to tear?
Right. And you could possibly get into the labia that way.
You're cutting from the base
to the right side. Yeah.
It's a ridiculous, there is something, and everybody recognizes this. Nobody talks about it. There is something about episiotomies or tears that's miraculous. Okay. What's miraculous about a vaginal tear is it never gets infected, right? And that makes absolutely no sense.
Right. It's by the rectum.
It's right there, the stool. It's not clean. Yeah. You're sneezing on it. I mean, it is the opposite of a sterile procedure, right? And there is stool. I mean, the woman just pushed out a baby. We all know women push out a lot of things when a baby comes out, right? And there's all this stuff everywhere. And you throw some betadine on it and you start sewing. Right? Anywhere else in the body, I promise you, pus would be coming out.
Yes.
I don't believe in my whole career I have seen one infected vaginal repair.
Right. It's very rare.
Very rare. Very rare. I mean, it
doesn't happen very often.
Right?
Yeah.
Because nature has this, we don't know what it is. One day they'll discover the protein or the enzyme that's floating around that's preventing infection from taking place in that area. But nature has this precaution that when you tear there, So I guess my point I'm trying to make is it's designed to tear. If it wouldn't be designed to tear, then there would be a lot of infections when you sewed it up. It is designed to tear and it's designed to heal because there were a lot of vaginal lacerations before there were sutures. I don't think sutures have been around forever. Women would deliver babies and they would tear. And then they would lay around for a week with their legs together and assuming they didn't get any DVTs or infection in lying in hospitals. That's why they used to call them lying in hospitals.
Yeah.
Used to deliver a baby and then lie around for a week.
Right.
Waiting for some infection to set. It was terrible. It was just all these ideas.
Well, my old timer midwives used to tell me stories about they would deliver the babies and then the women would lay there and then the ones that had the really bad tears would wait around for days for the doctors to come and sew them up on the 3rd and 4th degrees. They would wait there for days, 5-6 days.
Yeah, they need to check with their insurance plan what's going on there.
I mean, this is
crazy.
the 60s.
So, point is, again, tears are natural and they're in God's plan, which means that they're going to happen. They've always happened, and they heal. And there is no such thing as a natural right medial lateral tear. That doesn't ever happen. Yeah. The baby's head does not come out and somebody tears to the left. This is a modern construct that is hot now because somebody published a bunch of papers saying, this is the way to go.
Right, someone who probably doesn't work in the trenches.
I assure you, it may be a year from now or 10 years from now, somebody will finally say, oh my God, right medial lateral episiotomies are terrible.
Right. And what about left medial lateral episiotomy?
I don't know why. Why is it always right?
It's because it's right-handed.
Oh, so if you're a lefty, you go left medial lateral?
I guess. It seems like you would go left medial lateral if you were right-handed.
Another reason we don't like right medial, because it's asymmetric.
Right.
Why are we only cutting people one way and not the other way?
Yeah, exactly. It's not
That's our
fair to
major
the
problem.
left-handed people.
When JAMA comes out with the New England Journal comes out with their article, they'll be like, the asymmetry of right medial lateral
Yeah, it's not
episiotomies
fair.
are
It's the
offensive.
left-handed people.
Okay, so what's our take-home advice for patients, though?
Episiotomies are out. If you have a modern practice, you can assume and ask that they shouldn't be cutting episiotomies, and they aren't. And hospitals have this incentive
it's
program.
a dire situation.
Right. And the hospitals have this incentive program where they reward themselves and practices
How does the woman avoid a tear altogether? Is there a good way to avoid
So
it?
that I think we're going to talk about in another.
It's another podcast?
That is
we're gonna
another
talk about
podcast.
mineral oil and massaging.
Yeah, I think that's another podcast to come. Ask your doctor what their episiotomy or provider what their episiotomy rate is. I mean, I don't know any midwives out there that have really high episiotomy rates, but maybe there are some. But if your doctor episiotomy rate is like over 5%, that's probably way too high. Thank you for listening to this week's episode of True Birth. If you are interested in diving deeper into any of these topics we discussed, reach out to us on our website at truebirthpodcast.com. You can also reach us on our social media handles at Integrative OBGYN. We'd love to hear from you, and remember to subscribe.